Hi, good morning. Sepsis is a surgical problem. Yeah, I said it. Sepsis is a surgical problem. There's 70,000 children that are hospitalized every year in the United States. 7,000 of them die from sepsis. That's 3 times more than pediatric cancers. About 20 a day. So in this last hour, when you heard these TED Talks, a child died of sepsis. Hashtag facts. You can tweet that. I'm Samir Gadepalli. I'm a pediatric surgeon and a surgical intensivist at the University of Michigan. So I round on our ICU patients, I write notes and orders, I intubate, I manage ventilators. Actually, I don't write notes and orders, I have fellows for that, but pretty much everything else. And so what I hope to do in this talk is to prepare and energize everybody in the audience out here to go out there and save some children's lives from sepsis. So I'm going to give you, there's been some changes to the surviving sepsis guidelines, so I'm going to give you the lowdown on what you really need to know. And it's a very practical talk, and so just pay attention. And surgeons can really impact lives by following some key principles. And so, I'm a surgeon. I like simple algorithms. So I made one up. How do I do this? There you go. So this is what you got to know. SAVE. S-A-V-E. Source control, antibiotics, vascular access, monitoring and support, and equilibrium. Not too much fluid, not too little, maybe a little bit of Ecmo. I am from Michigan, after all. So before we go through these real quick, I'm going to talk about some definitions. So there's no such thing as severe sepsis anymore. It's just sepsis. And the way sepsis is defined is that it's a life-threatening organ dysfunction caused by a dysregulated host response to an infection. So look for an infection, labs, cultures, and look for organ dysfunction. So how do we define organ dysfunction? So a real easy way to do that is using what's called a quick SOFA, not the one you sit on at home, but it's a sequential organ failure assessment. And it's made up of 3 things. So it's mental status changes, elevated respiratory rate, 22 in adults, and a low blood pressure, so less than 100 systolic blood pressure in adults. In kids, you have to use age-appropriate criteria, and the heart rate may be a better marker than blood pressure. So quick SOFA, good way to look at organ dysfunction, mental status, respiratory rate, heart rate / blood pressure. Sepsis has a 10% mortality rate, so that's 1 in 10. So it's really important to keep that in mind. Septic shock. Now, septic shock, that's a 40% mortality rate. So that's more than 1 in 3 for those who don't know math. And so that's like that's you and the 2 people next to you end up with septic shock. One of you is dead. That's some serious shit. So this is where we got to really take some action. So there's a shock is where your tissues are not getting enough oxygen, so they shift to anaerobic metabolism. That's right, first year med school. And you get a bunch of lactate. So guess what your goal is going to be? Get oxygen to tissues so they don't make lactate. Real simple, right? That's what we got to do. Problem, though, is that we've done this goal-directed resuscitation. And there's been 3 studies that have been done in the UK, United States, and the Australian New Zealand group. The PROCESS trial, the PROMISE trial, and the ANZIC trial. And all 3 showed no difference with goal-directed resuscitation or protocol-based resuscitation. However, there's some key principles that are going to be important. Here they are. So let's talk about each of these in some more detail. Source control. So this is also a simple one to remember, 4 Ds. Okay? Drainage, debridement, device removal, and definitive measures. Okay? So drainage is going to be I&D, evacuate that abscess, put a drain in, get rid of the fluid collection. Debridement, get rid of devitalized tissue. So necrotizing fasciitis, you remove soft tissue. Decortication for pleural-based diseases. Device removal is removal of Foley catheters, central lines, and infected mesh. And finally, definitive measures. Definitive measures are resection of bowel for necrotizing enterocolitis, for example. Antibiotics. So start appropriate antibiotics early. For each hour delay in your antibiotics, there's an increase in mortality. So the duration of time between the time you diagnose to when the antibiotics are given increases your mortality. Kumar et al., Critical Care Medicine, 2006. So you got to give your antibiotics appropriately. So start broad and then de-escalate based on the cultures from your drainage. And make sure you de-escalate and reduce the amount of time that you're on antibiotics. A few things to follow with that will be a procalcitonin measure. So what is procalcitonin? It's a biomarker that's really specific for bacterial infections. So when a trend is more important than a value. So trend your procalcitonin. When it reaches normal levels, you can stop your antibiotics. Otherwise, Sean Rangel is going to come after your ass. The other thing to remember with your antibiotics are, stopping antibiotics is just as important with starting antibiotics. Otherwise, you breed antibiotic resistance. And he's right. This is really important. So in sepsis, we got to start our antibiotics early, but we also got to stop our antibiotics on time. So there's a Stop It trial that looked at abdominal sepsis. And it says, in 4 days, you've achieved adequate control that you can stop your antibiotics. Randomized multi-center trial. So 4 days for abdominal sepsis. Next, in terms of the clock starting, right? So this is really important in terms of starting early. It's from the time your blood pressure is checked and is low to when the antibiotics are actually hung. So sometimes that means you got to get that IV in that first hour. So that's the next step, right? Vascular access. That's where we come in as surgeons again. And so vascular access doesn't just mean 2 large bore IVs in sepsis. Vascular access means that you might need continuous infusions. So you got to get a central line in and an arterial line in for monitoring ASAP. I tend to use ultrasound because I don't like to randomly poke at vessels. But you got to get your lines in. And then your monitoring, I use a lot of ultrasound and echo to help guide my resuscitation. And it's a change from CVP and SWAN numbers. But it's a useful measure because it's dynamic and you can continue to follow it over time. It's at the bedside. It doesn't involve moving anything. And it's a little bit non-invasive in kids who don't need the infusions. In terms of goals for what you're trying to achieve, in terms of lactate, I know I mentioned it earlier, but there was an Andromeda shock study just came out, 2019, Hernandez et al. And JAMA, and it looked at using capillary refill versus lactate as a measure. And what it found was cap refill was just as good as, if not better, than, and this is in pediatrics, just as good as, if not better, than using lactate levels. And that's really important. It had the same amount of 28-day mortality, ventilator-free days, renal replacement-free days, and in fact, there was a almost statistically significant difference in mortality where cap refill had a 35% rate and the lactate level group had a 43% rate with a P of 0.06. So you're like, wow, how is that possible? And it's because the lactate group got a ton more fluid. It was actually over-resuscitation trying to correct that lactate. And over-resuscitation is bad. So it brings me to my next principle, equilibrium. So we know that fluid overload is associated with mortality. And 30 ml per kilo is a good number to use for your sepsis for volume. Isotonic fluid, 30 ml per kilo. So they come in, they're hypotensive, you give them some volume. The FEAST trial, which looked at boluses in children, African children with severe infections, identified that over resuscitation increase their mortality rate in sepsis in children. And so what you have to do is you have to constantly ask yourself, is this shock really still hypovolemic? Because remember, shock can be 4 different things. It can be hypovolemic, it can be cardiogenic, it can be neurogenic, or it can be obstructive. So things like tamponade or pneumothoraces, so forth. So once you give your 30 ml per kilo, start considering other things. 1, albumin. So the ALBIOS trial looked at, ALBIOS trial, looked at use of albumin in sepsis and showed that you need to decrease the amount of fluid to achieve your goals. 2, think about blood. So the TRISS trial, TRISS, looked at transfusions in septic shock and identified that a hemoglobin of 7 would be a good adequate number to shoot for. And then 3rd, consider your pressors. So what pressors do you use? So that's where echo is really helpful. Is my SVR low, and what's my heart function like? So those are my 2 questions, right? So have I given enough volume? Is my heart pumping enough? And is my SVR what I need to address? So typically in kids, I start with dopamine in the babies and norepinephrine for the older children. Most of them have pretty good heart function. And that usually changes if I have somebody with renal failure. So there's a VANISH trial, VANISH, that looked at vasopressin versus norepinephrine, and vasopressin was a good adjunct to use in those with septic shock and renal failure. So renal failure, think about vasopressin, otherwise norepinephrine, and then dopamine for your first lines. And then in terms of your shock, if you find that you have warm shock, you have adequate blood pressure but inadequate perfusion, so good blood pressure, bad perfusion, use milrinone. Milrinone is a really good adjunct to get blood flowing with the heart. It's a good inotropic support. So really simple. Dopamine or norepi, vasal for renal failure, milrinone if you need heart support. So those are good adjuncts to start with. Then, as I'm starting my second pressor, if they're not improving, that's when I consider steroids. So there's no data to support doing a stim test in this setting. As you start your second pressor, start your steroids. Typically, I use hydrocortisone at 1.5 to 2 per kilo every 6 hours. So steroids, second line at the time of my second pressor. And then, so let's walk through this for a second here. So if I have a patient who comes in, say, peripheral appendicitis, looks sick, looks septic, get your drain catheter in, put some IVs in, get a central line in, arterial line, admit into the ICU setting, give them your isotonic fluid boluses, 30 ml per kilo, check their albumin, check their cultures, procalcitonin, antibiotics. We're good so far, right? So patient's still getting worse, not improving, now on 2 pressors, on hydrocortisone. Think about Ecmo. So that final consideration of Ecmo is key to remember because Ecmo helps with oxygenation and cardiac output, but it has a really difficult time with SVR. So if your systemic vascular resistant SVR is really low, you may still need pressors, even on VA Ecmo. So somebody is in severe septic shock, like it's really bad. Even on ECMO, on VA Ecmo, you might need to use some pressors. And it's because it gives you oxygenation, it gives you oxygen delivery with cardiac output, but you need something to get your vessels to be tighter. So the other thing with ECMO is don't just crank up the dial to get more flow. So place the largest size cannula you can get, add an additional drainage cannula if you need to, and then consider a central cannulation if you need adequate flows. McLaurin et al. From Australia. If your SVO2 is 70%, you have plenty of flow. At that point, you should start thinking about going back. Do I have adequate source control? Am I on appropriate antibiotics? Is my vascular monitoring appropriate? Am I missing something else? Remember, your key is equilibrium. Your final E can also be ECMO, which is in this case. So keep these 4 concepts in mind to save some lives. Source control, antibiotics, vascular access monitoring support, and equilibrium. Remember, sepsis is a surgical problem.